I'm Cass Naugle, Executive Director of the Alzheimer's Association Greater Maryland Chapter, and we are waiting for our registrants to join, but we thought we would get started since we have quite a number, over 150 participating today. We're so pleased that you're able to join us. We felt that it was really important to provide the voice of long-term care in COVID-19 and the experiences that they are having. And also the COVID-19 pandemic is especially challenging for people with dementia. There, about 48% of residents in nursing facilities are living with dementia, and 42% of residents in residential care facilities have Alzheimer's or another dementia. And persons with dementia are particularly susceptible to COVID-19 because of their age and possible coexisting medical conditions, and also because they might not be able to follow instructions about keeping themselves safe and risk-free. According to some estimates, there are about 27,000 residents and workers who have died from the coronavirus at nursing homes and other long-term care facilities across the country. And while we have heard so much across the country about the healthcare heroes in acute care, the staff in long-term care settings have been pretty much overlooked. Even though here in the state of Maryland, Maryland was an early leader in recording deaths from people in nursing facilities from the coronavirus. But even now, 50% of the deaths in the state are comprised of residents in nursing facilities. So we wanted to shed some light on these issues, and we've invited a distinguished panel of our good friends and partners in Maryland's long-term care industry who will share their experiences during the pandemic. And our distinguished panel, excuse me, includes Joe DeMattos, President of Healthcare Facilities Association of Maryland, Alison Cibrowski, President and CEO of LeadingAge, Kevin Heffner, President of the Lifespan Network. And our moderator today is Scott Townsley, who is a consultant with the UMBC Erickson School and a board member of LeadingAge Pennsylvania, which is one of the largest organizations for culture change in the country. So I'm so very pleased to turn it over to Scott.
Great. Welcome, everyone. I'm honored to be here as moderator with the distinguished panel. I like those words. I probably won't need to do much other than maybe a little lion taming now and again. My hope is that this is very interactive. For those of you in the audience, there's a chat feature that should be at the bottom of your screen. And as we go through this, if you've got questions, if you'd write them in the chat box, we'll be able to look at them, and we've reserved the last 15 minutes to be able to take some of the questions and respond to them. You know, in the old days of 4 months ago, at a conference like this, we'd tell everyone to turn their cell phones off so that it wouldn't be disturbing. If you've done any Zoom sessions in the last 3 months, you'll appreciate that you may hear some dogs barking, you may see some grandchildren or children running through, a spouse or partner may show up. That's just the nature of where we are in June of 2020. So to get started, Alison and Kevin and Joe want to give you an opportunity to just make some opening comments of how we got here. And we'll dig deeper into what you're seeing And throughout, we'll be looking for your perspective, including Cass's, on what lies ahead. But which one of you would like to jump in first and just give us some of your opening thoughts? And since I'm a graduate school professor, if no one volunteers, I'll just call on you.
Allison, I think you're the newest, so you should go first.
Good idea.
Sure. I guess, Scott, the three of us are all too polite and deferential, so we'll try to not do that so often. Hi, everyone. Alison with LeadingAge Maryland here. And, you know, all of us who are on this call today have a great passion for what we do. We got into this field because we care about people and we value the lives of older adults, and are working to try to create more opportunities and to change perceptions. But I don't think it's any surprise to any of us that are here today that you know, we see places in our nation and our communities where older adults are not a priority or they're not valued. And so, you know, I think that from the beginning of this pandemic, older adults were not given the priority that they should have been in protecting them. We knew from the beginning that older adults and those with pre-existing conditions and those who care for those individuals would be at greatest risk. And we really did not see federal and state policy keep up with that need to really prioritize them in many ways. And so we know more about this virus today than we ever have. I can't believe, Scott, that it's only been 4 months since we started this. It feels like a lifetime. But we now have a greater understanding of how this virus works, how it affects people, what we need to do to really fight it. And I think that after the conversation today with my thoughts, Kevin and Joe, I think, you know, between the three of us, we likely have some thoughts on what it really would take for us to take next steps to continue to protect people. But I guess just as opening thoughts, that's kind of where I'll leave it, that we, you know, we need to continue to prioritize older adults and really think about what that means. And I'm excited to be part of this conversation.
That's great, Allison. And so, Joe, since you suggested that we go in order of newness, let's go to Kevin next, and then we'll come to you last.
Yeah, well, thanks, Scott, and thanks so much for having all of us here today. I think this is an important conversation and one worth having. You know, no one wished for this. No one anticipated, I think, the twists and turns that we've taken the last several months, but I always look for the silver lining, and I think one of the silver linings in what we've all been through is that we've come closer together. Joe and Allison and I and our organizations have really pulled together in the same direction on a variety of fronts, and there's been some real positives that have come out of that for older adults. I think we've made a fair amount of progress, but there's a long way to go. Highlight 2 areas of important focus. Number one, I think we need to do everything that we can to be sure that we are better prepared from the standpoint of so that if and when there is a second wave, a third wave, that we are certainly better prepared to protect those who care for older adults as well as their families and residents and clients themselves. And so I think having a storehouse prepared and available is going to be important going forward. And the other area that I think we need to be better prepared is as it relates to surveillance and anticipating using data, using technology where outbreaks can and will happen, and deploying resources, limited resources there proactively as opposed to reactively. There are a variety of things that I think we can do, and we're hard at work doing that, and just looking forward to the summer months continuing to work together, and in those 2 areas particularly, but in a variety of areas as well, to make sure that we're best prepared to provide the best care and the best services that we can, knowing what we know now.
Thoughts? Thank you. Joe.
Hi, let me unmute myself. Yeah, I want to join Kevin and Alison in thanking Cass and the entire Alzheimer's Association family for bringing us together for what's a very important discussion. I've said this on previous calls. I think it's appropriate and timely to mention that all of us have a connection to the horrors of COVID-19 and this novel virus. And it's especially powerful to have this discussion with the Alzheimer's Association for the reasons that Cass mentioned on previous calls, that I have a personal connection and family background with dementia and diabetes. And it's appropriate to tee that up relative to COVID-19 because as Alison said, we knew early on that this novel virus was going to mercilessly attack older people with pre-existing conditions, and that specifically it was going to be a difficult virus to manage in environments where people, not patients, not residents, people across all settings are also impacted by Alzheimer's and other dementias. I just want to add a couple of points about where we've been and where we are likely going to be, where we're going. As Alison says, and as Kevin pointed out, we've been learning. We knew this was going to be bad, really dating back in January and February. And we told everybody that we knew in state, federal, and local government that it was going to be bad at that time. And, hindsight's 2020, but the federal government really didn't prioritize our sector early on. And that's just a fact. We also learned that this was not a novel virus like other viruses that we had experienced previously. And really just getting to the bottom line of three bottom lines and kicking it back to you, Scott, is that the only thing that would have prevented the major outbreaks that we've been experiencing with COVID-19 with older people and pre-existing conditions across all settings, including senior housing, assisted living, and nursing homes, would have been testing in like January or February of this year. And that didn't happen. And we knew, of course, that pre-existing conditions were a determining factor. And in the absence of a vaccine going forward, the only thing that's going to really help is continued testing, continued isolation, and applying best practices. And so we're going to be with this virus for quite some time. And then finally, ending on what Kevin said, one silver lining of all of this is that it has brought all of us closer together to share our respective strengths. And we value the respective strength of the Alzheimer's Association and AARP, and in my case, LeadingAge Maryland and Lifespan and HFAM, because we have these shared strengths that are unique to us, and we bring them together, we're stronger together. So Scott, with that, I'll throw it back to you.
That's a great way to help kick things off. So thanks for doing that, Joe. One of the things that frankly compelled me to want to be part of this was the idea that, and it was promoted as a public conversation, that we've got leaders of four key associations, essentially in a virtual room, to have a conversation. Yeah, it'll be among the four of them, but through your questions, it'll also be with caregivers, with other providers, with policymakers, and this is an important conversation because, Joe, as you're highlighting, it's not over. It's, we may, as some have used the analogy, we may be in the eye of the hurricane where it's calm, and then as the eye moves, the calm is lost. I'm going to direct this, Joe, to you, but it's coming to Kevin and Alison also. I was curious about what you're hearing today from members And you don't have to spend a lot of time on this, but as I think about the three of you, really the four of you, you largely represent every nursing home and senior care provider in the state, combined. What are you hearing today from your members, and how is that different than what you might have heard, let's just say, a month ago?
Just first say that all of us are hearing from members. We're sometimes hearing from workers. And in my case, I'm often hearing from family, both associated with our sector and caring for a loved one at home. So let me just first talk real quick about family members caring for people at home. And it's sort of a reoccurring theme, and that is worry and overwhelm. On a one-to-one relationship with a family member suffering from dementia at home, locked in with very little respite care, it's challenging. It's always challenging, but you add the scenarios of social distancing and managing the illness and cabin fever and a change in routine, and it's challenging. We're hearing the same from families with loved ones across all of our settings, senior housing, assisted living, nursing homes, worry and concern. So we're spending more time and advising our members to spend more time to communicate with family members, and we've been doing that since February of this year. From the members, they're concerned about what's going on in New York, where weekly testing is ordered and it's not working because you're getting tested on a Monday, you're being required to be retested the next Monday, and you're not getting results from the first test until next Wednesday. So you're testing twice in a week and not receiving the test results from the first test before you're being required to be tested a second time. So we're worried about that there's still a lag time in testing. And we're worried about still PPE. There is no national provider that is providing 100% of an allocation in our sector. Under Kevin's leadership, our three associations went out and bought millions of dollars worth of PPE for our respective members. But right now, if you're in a nursing home or assisted living today, or in senior housing, and you call your national provider and you say, I need 100 of these gowns, masks, whatever, you're not getting 100% of your order. You're getting 60 or 70% of your order. And you have to augment that with what you can get going forward. So general themes are worry and concern about today and tomorrow, support and respite, testing and the effectiveness of testing, really related to lab capacity, and ongoing supplies of PPE.
Great. Kevin, I'm going to come to you, and then Alison next. Cass, I'm also going to come over to you to hear what you're listening, what you're hearing from members. But Kevin, how about you?
Yes, Scott, I would echo everything that Joe has said related to PPE and testing. I would add also there's overwhelming concern as it relates to connecting residents with families. What technology is emerging that's going to enable us to do that without having to pull nurses off of the floor of doing the things that they need to do to provide care. So, we're all familiar now after these many months with how Zoom works. We certainly all know how FaceTime works and similar technologies, but in almost every case, that requires people to enable that. When you are going through testing, as Joe said, and having direct care workers who are who test positive and need to home quarantine, you're having to replace those resources, and it makes it even more challenging to have staff members enable communication between residents and families, which we all know and certainly agree is incredibly important. But it's also important to provide nursing care directly. And so that's a real challenge that we've been hearing from members about. I think, and I'll leave with this, I think too that, our members are telling us that there is a real challenge in getting beyond sort of the historical punitive type approach to interaction between regulatory agencies and employees, staff members, and we've got to find ways to get everybody, as John Erickson used to always say, to get everybody around on the same side of the table. It's much easier said than done, but I think when you hear concerns about we're going to be given additional dollars to help make us whole for the money that we spent on PPE that wasn't budgeted, for the money that we've spent on additional nursing that's been budgeted, and the response may be, well, we're going to require additional nursing hours. Well, no, this is to make us whole financially. This is not to add regulatory requirements. So, I think we need to find ways to help bridge that gap. It's an easy thing to say. It's a very difficult thing to do, but I think we need to keep trying.
Good points. Alison, what are you hearing, and has it changed over the last month or so? You're on mute, by the way.
Sorry, I obviously have not figured out Zoom yet. I echo everything that Joe and Kevin have said, and so LeadingAge Maryland, it's interesting. We are able to bring, I think, a bit of a different perspective as well. We have the biggest bulk of our membership is actually affordable senior housing settings, and so we have kind of a big foot in that world of subsidized housing and what that looks like. And I think some of the things that we have seen related to what I'm hearing from members now. So, a couple of months ago, it was focused on kind of shutting, how are we going to protect residents? How are we going to restrict visitors? All of these things. And now we're having to think about, well, gosh, the communities around us and our states and our counties are reopening. So what does that mean for us? So really that question of how do we and when do we lift restrictions on visitors in non-healthcare areas? And this is particularly challenging for our life plan community members who have varying levels of care on the same campus. So they have, several hundred residents who are living completely independently, and yet they have also not been able to visit with loved ones. And, that's, we know, very painful for families. It's also hard for our members to see. I had a member tell me last week that a family came to them or called them and said, I'm beginning to wonder if I will ever get to see my loved one again. This is a really real and very felt painful situation for families, for staff who are trying to kind of bridge that gap and help people stay connected. So I'd say, kind of thinking about reopening, certainly the testing question. I had a call with some members last week around kind of ongoing testing and what their thoughts would be if we had a magic paintbrush to kind of decide what that would look like. And some members were throwing out numbers of, if I had to test my staff every week, like we're seeing in New York, like Kevin said, it would cost me $35,000 just to test everyone once. And with the incredibly high costs that our providers are already paying related to needing more PPE, increased staffing costs, all of these things, it's just not sustainable. And so there really has to be a better way to address that challenge of testing. And I think the last thing I would say is again, just echoing the PPE issue, and so thankful that the three associations were able to really work together and partner on that. And I think that the immediate crisis, if you ask our members today, they have what they need for today, but they don't have what they need for 2 weeks, 2 months from now, and they don't know how to effectively even project that right now. That's a real challenge, is will it be there for me to order when I do need it? Do I need to keep just ordering as much as I can right now, and how do I pay for that? So there's just a lot of unanswered questions as folks are really trying to prepare, as Kevin said, for if we're looking at a future a second wave of this. So I'd say those are some of the things that we're really grappling with right now.
It's a great point. Thanks for sharing. Cass, coming at it from a perhaps different perspective, what are you hearing today? Has it changed?
We went to working at home on March 13th, and for a few weeks we heard nothing from families, and I think that they were grappling with, okay, the daycare center's closed, I'm working from home, I'm laid off, and my loved one needs my attention. And during that time, our program staff were struggling with new technology and trying to convert all of our services into virtual programs. So our support groups and care consultations, our education programs, and using Facebook Live to promote what's going on and provide virtual yoga and sing-alongs and travel logs and anything that we could do to help occupy families at home. As time went on, by far, the most heartbreaking calls that staff have received are from family members who haven't seen their loved ones since early March. And, maybe after providing 5 years of, 24/7 care and feeling so totally responsible, not being able to do that and to comfort their loved ones at this time. And there are no easy solutions for it. I just know that my staff are just trying to support families, and it's been very, very difficult for them to take these calls.
Sure. The four of you have identified some, it seems sort of empty to say it, but some really critical issues. And any of them, frankly, we could take up the rest of our time. I want to hit several of them as we go through this. And Joe, I'm going to pull something from you. You can jump in, or Alison, Kevin, Cass, feel free to jump in. But when you started by talking about worry, in my mind and on my paper here, I kind of put worry and fear together. That you worry too much, or you worry enough, it turns into fear. Fear from the staff, and will I be infected? Fear from residents and consumers. Fear that they'll never see their loved one. And then Alison, as you brought us to the present, essentially saying, look, we've got reopening, and those worries and fears are going to be there as reopening happens. Celebrating that connections back with family can happen in different ways. Talk about what your provider members are doing, what the associations are doing in terms of, and I put it in the category of protecting residents, protecting staff, particularly as we look at reopening, but also about how do you address that fear that's probably going to be there for a while rather than just going away.
Jump in, Scott.
Thanks.
So what made the fear and worry different about COVID-19 from the start was first that it was mischaracterized. And we were learning and developing as we went along. When the first CDC announcements came out in January, COVID-19 was described as the latest novel flu-like virus. And in Maryland, the first alert on COVID came out from the doctors from MedChi, and we followed that with our HFAM alert on January 29th. But what made the fear and the worry different and more intense with COVID-19 was that it sort of robbed us of knowledge and togetherness and we felt like our hands were tied initially. And so what we found going on was the best antidote to fear and worry was knowledge, empowerment, advocacy, and communication. So if, for instance, is that we had our first COVID case in Maryland on March 15th in Elkridge. And one of the first things we told people and advised providers on and families on relative to fear and worry was that we were taking active steps to identify workers in Elkridge that worked in other centers, right? Because immediately you're like, oh my gosh, there's a COVID case in a nursing home in Elkridge. Where else do those people work? And so we were proactive in identifying that and transparent on sharing that best case with people. But the reality is, 113 alerts later and working many times in concert with Kevin and Alison on joint updates for the entire sector, the way we handle fear and worry, which is going to be with us for a while, is by sharing the facts and the truth, adapting, and if we can't be together to support each other physically, personally, armed with the facts and knowledge and best practices to support one another from a distance. So, we, as you said, Scott, we could talk this whole time about the different fears. The fear that Kevin brought up with regard to funding and regulatory overreach. The fear that the fact that our skilled nursing and rehab centers are about 20% less full than they normally would be, and they're not helping as many Marylanders in need, or the workers or the families. We could talk about, we could spend our whole time talking about legitimately fear and worry. But I think what's important in that discussion is, what's the antidote to fear and worry? And the antidote is knowledge, communication, transparency, and support. And that's what we're focused on.
Great summary, great response. Kevin, Alison?
Yeah, I'd love to jump in on that and just really appreciate all of Joe's thoughts on that. And I think he hit the nail on the head. I think it, we're at a point where the fear and the worry is real and it's here. And I think one of the most important things we can do is acknowledge that, acknowledge the incredible stress and pressure that our frontline workers have been facing. And we were really glad to see last week that Maryland is now offering free mental health services and support to frontline workers. And we were really glad to see that. It's an important step, I think. And I think just continuing to acknowledge and support workers in every way that we can, to support family members, to support residents who, I was just talking with a member just about how there's some residents who have not left their room now in how many months, or have barely left their room, and just how all of us are largely at home and how that can feel stifling. But imagine not even leaving a room, and just the importance of acknowledging that and really finding ways that we can continue to engage folks. I think another piece around kind of just protecting residents and staff is, thinking outside of just skilled nursing. There are so many older adults who are living in the broader community and in senior affordable housing, and those sectors have received even less support and guidance than skilled nursing. And, talking with some of our affordable housing members who have jumped through hoop after hoop to try to help residents access testing, trying to ensure that the residents that live there are able to get groceries regularly, trying to make sure that they're able to get medical and mental health services in their setting, and all the while not having received much support and guidance at all from either federal or state agencies. So I think there's just a lot more that needs to be done and looked at, and it's important for us to remember the many, many folks that are not living in a skilled nursing facility.
Great point. Oh, Kevin, do you want to jump in or?
Yeah, I would just, I think Alison and Joe are spot on in every way on this. I think what I would just add to the mix is, you know, Scott, you teach strategy and innovation, and in times like these, innovation rises to the occasion to solve problems. And so I think we are seeing that happen. We're going to continue to see that happen. It's been, I think, positive to see the way that society in general is beginning to embrace telehealth, and the way that regulators are beginning to look at telehealth as an available option to solve problems, to solve challenges. I would again touch on, you know, the importance of technology to help residents and families in whatever setting to be able to connect in a way that doesn't require a whole lot of assistance. You know, let's find some innovative ways for people to be able to connect with each other. I think too, I would just add that, you know, there's a reason that this is called novel. It's different. And I think if we think back to a couple of months ago, assumptions that we were all making because the experts were telling us that, you know, these are the characteristics, I think they were learning as we were learning, and things have changed. And so there's a lot still to learn. I think in some cases, you know, social media can be an enemy to true knowledge and understanding. You know, you see people fill in the gaps, and, you know, with misinformation and false information. And I think it's going to be important for us to really keep our eyes on the ball as it relates to what science tells us. And as we begin to understand better, as Joe and Alison said, you know, doing the right things to keep people safe and to err on the side of caution.
Which is a great point. Cassie, you want to jump in or?
Well, I do agree with Kevin that if there's any silver lining in all of this, I think the use of technology, there's just greater recognition and appreciation, and why haven't we done this sooner? But especially with telemedicine, and if you can avoid a transition to a hospital with something like that, just better for everyone involved. And I think that also for families, there are new technologies. We're working on a project with Hopkins that are technologies that are very user-friendly for families and people in residential care, that I think will be coming down the pike.
Oh, great point. So I'm going to go back to something that Kevin mentioned and ask another question. I'm the chair of a quality committee for a small nonprofit multi-site nursing home and assisted living provider in New Jersey. And we've had 23 deaths, sadly. But we had a board meeting last week and tracked what was happening, kind of looking backwards with the CDC guidelines, and essentially tracked when the staff were doing that innovation, Kevin, that you're talking about, of moving beyond what CDC had recommended. And so we took this action, and that's starting to flatten in this facility and then in that facility. So here's my question for you. You know, we don't have a magic wand, and we've talked some about what needs to be done. But if we said, look, we can't just rely on the CDC or departments of health to tell us what we should do as we're looking forward. As you think about innovation and you think about technology, you think about data, all things that have come up, you think about dollars. What's the 1, 2, or 3 things that need to be focused on And I'll just put an artificial timeline for the remainder of 2020. What do we need to do as we're continuing to face, as you referenced, Kevin, this novel virus, and entering into another phase of unknown? What's yet needs to be done? Alison, do you want to jump in?
Sure. Yeah, that's a really good question. I think that there are two kind of immediate things that I think will be really important, and they've already been touched on, and that's just the issue of how we navigate reopening, and the testing piece. So you may have heard comments around, we have prevailed on testing, but this is simply not true. Nursing homes and other providers still don't have access to testing, and as Joe and Kevin have shared as well, when testing is taking a week or more to get results back, it's just not helpful. And so I think that is hopefully one way that technology can speed up and maybe create some new opportunities for rapid testing and expanding that, so that providers could have on-demand access to rapid result testing. That would just revolutionize how we're able to use information more quickly and really protect more individuals. And I think that, just another big piece is thinking about a more comprehensive plan for reopening. Right now it's kind of patchwork, and in some ways that's good because different areas have been affected differently, but we still need a plan that ensures that providers in settings that serve older adults have the immediate access to PPE that they need as things are starting to reopen, that there's enough resources for them to kind of mitigate this additional risk from residents that are now traveling on and off campus. So I had a member say to me last week that they're just having a lot of conversation with their residents around the fact that we are intentionally not keeping pace with reopening in the broader community because of the very nature of who lives on our campus and how important that is. But, it's just constant conversation around what are the best practices when really there are no best practices yet for reopening after a pandemic because none of us have done this before. So I think there's a lot of opportunity there for us to find creative ways to use technology, data to really come up with some solutions and real best practices.
Great points.
Scott, just jumping in here.
Yeah.
One of the early tragic learnings coming out of Kirkland, Washington, that is a better, less tragic learning today on June 9th, is that there is no cavalry in this pandemic. Nobody comes to save you because none of the resources are sort of teed up by what you know at the right time in the right place. At least they haven't been thus far. So putting a positive June 9th frame on that, because from your innovation and strategy class and my leadership class that I'm a big fan of 360 leadership. Putting a positive lens on that is probably the number one thing that we can do going forward, recognizing that all of us on this call, we're the cavalry. And we need to take 360-degree ownership of the challenges that we face and create public-private partnership where we can, where government and others are not able or not willing to step up. So I would say the number one thing to realize is that we have an opportunity here for 360-degree leadership and to own it and to fix what we can together rather than relying on others to fix it. Now, there are things that we won't be able to fix. Testing, the estimate on testing for a year for the country, for our sector, from senior housing to assisted living is $7 billion, right? So I don't know about you, but we don't have that, laying around, all of us. But there are other things that we can fix. And, you know, so there's some examples of that. You know, our members, the people working for them, the families engaged in care, they all have ideas about how we can take 360 ownership going forward. We have members this week that are doing starting drive-by visits where a whole lawn is used and cars can pull up, and there's a barrier, and they're taking a page out of the class of 2020 graduations, and they're initiating again visits. As Kevin spoke about, you know, the use of technology, but that's a double-edged sword, because you have people providing care that need to provide care, and when they're not doing that, then using technology. But again, I think it's relying on the knowledge, what we would call in Hawaii, the kuleana, the individual specific knowledge of families, caregivers, organizations, and recognizing that we have 360 ownership to innovate where we can.
Great point. Kevin, thoughts?
Yeah, I think Joe and Alison are right on target as usual. I think, you know, to Joe's point about finding ways to solve problems, there is no cavalry coming. And so early on in this process, we collectively figured out a way to provide some relief on PPE. You know, none of us, the three of us, thought that we would be working on supply chain stuff in June of 2020, but here we are, and we've actually gotten pretty good at it, I think. And you know, we are not the panacea. We're not going to solve all providers' PPE problems, but we've made some real headway in being able to relieve some of the pressure. One of the other things that we're working on is trying to find a way to do a better job of painting a picture of this field as not only a noble but a rewarding profession to go into, and specifically talking about ways for folks that have been laid off or let go in hotels, in restaurants, whose jobs may never be back, but certainly aren't going to be the same as they were. What if we're able to paint a picture and to create, as we've worked on together, an online CNA, GNA statewide program that would enable people, for instance, who have been laid off in a restaurant that may or may not be reopening, to consider going into nursing. Well, there are huge numbers of people that we can move if we can paint a picture that inspires them and that gives them a view of what their future might look like outside of the restaurant field, outside of the hotel field, where they may start as a CNA or a GNA and then progress, you know, become an LPN. Maybe they, you know, find a career path that involves them going into the business office or into HR or into dining services. You know, we collectively, thanks to Alison's and Joe's leadership, ran a full page ad in the Baltimore Sun the last several weeks, talking about this field's need for support and for partners in helping to solve some of these problems. That's a great start. But I want to go all the way back to something Alison said early on about how we value older people in this country. We need to continue to have those conversations in a meaningful way to inspire people to go into the field, but also to help government officials, federal, state, and local, to look at what providers do in a different way that is noble, that is inspiring, caring for the most vulnerable in our population. And so I think we've started, we need to continue to do that.
Right. This is a good time to transition to the questions that are, some of the questions that are being raised by the audience. And I'm going to take several of them and mold them into one. And it relates to conversation that I think each of you, all four of you have raised before, and it's the impact of social isolation. So I'll frame it this way. a military retirement community client of mine probably first introduced me to what they would refer to as the invisible injuries, not just for soldiers in combat, but social isolation, invisible injuries. And you all, frankly, everybody on this call probably knows more than I do about the research that's already been done in terms of how social isolation increases the risk of cognitive decline. But I want to throw the question about isolation to you as open-ended as I can make it, to recognize that it's the invisible injury. It's maybe the most widespread injury. You know, we had X number of diagnoses, but how many people have been impacted by the social isolation? Alison, you've a couple of times appropriately identified reopening as an important topic, and others have talked about, you know, the drive-through opportunity. But talk about the effects of social isolation. Talk about what we can do as the cavalry, and talk about, you know, in a hopeful way, where we might end up 6 months, a year from now. Alison, I see you're unmuted, so let's go to you first.
Sure, I'll jump in. You know, I think social isolation was a challenge for our field before coronavirus. And so I don't think it's a surprise to any of us that it is such a challenge now. And I think there are some bright spots. I think that, you know, the fact that folks were able to access CMP funds to purchase additional devices so that they could facilitate more visits in skilled nursing settings is definitely a bright spot. I think that, you know, we've seen members do incredibly creative things. Things like window visits. We've all seen the great pictures and videos of some of those examples. I spoke to a member last week who said they have a large outdoor campus and there's a fence that separates the campus from the rest of the community. And they had some residents who were having a picnic from across the fence, appropriately social distance. But there's also talk, and I saw someone made a comment about this in the chat about, you know, is there a way that we can start utilizing outdoor spaces now that it's getting to summer? And we have seen members across the country doing that. And so hopefully that's something that we can do here in Maryland as well. Folks are also really rallying their volunteers to make calls to residents in both life plan settings and affordable senior housing settings, and you know, using mail, going back to snail mail, and having residents connect with students. So, you know, I think that social isolation is not a new challenge to us. And I think that we have an arsenal of tools that we are learning how to use more each day. The issue of connectivity, especially for folks who are living in affordable senior housing, that's not, they don't always have access to Wi-Fi or to a device that can help them easily connect with other people. So there are real challenges there, and LeadingAge's Center for Aging Services Technology and ARP Foundation are working on some creative ways to help bridge some of those gaps. But, you know, I don't think there's a magic answer. I guess I'd just say there are some bright spots. I think all of us are valuing social connection now more than we ever have, because we're feeling more acutely what it feels like without that. And I think we just have to keep finding creative ways. I'm not sure what else to say there. I'd be eager to hear what Joe and Kevin have to contribute.
Joe?
Well, you know, as Alison points out, I think our sector struggled with social isolation of residents, patients, workers, and families pre-COVID-19. And COVID-19 has shone a bright light on many things. It's shown a bright light on that isolation. It's shown a bright light on the healthcare disparities and the social determinants of health. And it's shown a bright light on, as Kevin has said, the healthcare heroes that worked in our sector before, during, and will work in our sector after this crisis. there's one cross-cutting thing to all of that, Scott, that I find interesting, and that is that all of that language that I just used is very much medical language, right? Social determinants of health and healthcare disparity, patients and residents and workers and caregivers and healthcare heroes. I think to Alison's point and looking forward, I think those of us on this Zoom have long known that really what we are in is in the human engagement enterprise. It's often looked at from a scarcity perspective on a medical model of something is broken and let's fix it. And really, when you get right down to it, what COVID is teaching us yet again is that how can we be in the business, in the enterprise, forgetting how we're structured, for-profit, nonprofit, whatever, how can we be in the business of helping people to be their best selves in the best, most safe, appropriate setting for them, whatever that setting will be. And when you start to look at that, you realize that we are really in our best selves, we're really in the engagement business. And so going forward, we're challenging our sector to think about engagement, employee engagement, family engagement, care engagement. And again, you know, one of the bright lights that COVID shown in our sector, specifically on skilled nursing and rehab centers, that maybe most of the public didn't realize, is that the majority of people that receive quality care in skilled nursing and rehab centers, and a bunch of them in assisted living, just a few years ago with acuity creep would have been receiving that care in hospitals. These are medically really challenged people. So the question going forward is, across the entire continuum of care, is how can we all work together to have people engaged in the best possible care and support, again, not just of patients and residents, but of staff and of families. One thing that we wrote about last week was just the reality is that prior to COVID, probably about half of the people receiving care in skilled nursing and rehab centers didn't have any visitors, right? And so moving forward, how do we account for better engagement, not just for the folks that had visitors and have family members engaged, but how do we look at what we do as we're an engagement and wellness enterprise across all settings. So I know I hit a bunch of different bases there, but you can tell it's a subject that I care passionately about.
Absolutely. Cass, I want to come over to you to see if you have any thoughts about the issue of social isolation and its impact and decline.
Well, when we think about it, we think about the dyad of the family caregiver and the person with dementia. And we've taken some baby steps. Before all this, we had programs called memory cafes, and they were designed for people with younger onset or early stage and provide the opportunity for couples to develop a social network. And we've been able to do it with some success online. And the good thing about technology is that there are no geographic barriers. So we have people from all over the state, even out of the state. But again, just people having the opportunity to socialize and share their stories. And so I think that we'll continue to learn from these small experiments and hopefully expand them through our other services. And again, I think that's one of the opportunities for growth.
Great point. We're going to go a little long. Hopefully the panelists can stay with us. Just a couple of minutes because there's several questions that I want to get to. But I want to read a comment that was shared for some of you who haven't seen it. There are many Maryland Alzheimer's advocates on this webinar that look forward to being the cavalry and help advocate for these issues in the state. So the cavalry has heard the call, Joe.
Counting on it.
There's a, you know, as we talk about the healthcare heroes, it also touches on a couple of questions that have come in about CNAs, about nursing assistants, and just about staff generally. And so I'll frame it this way. One said, it's great to be able to think about, certain folks who are unemployed coming over to our side. And Kevin, as you were highlighting, to see this as an opportunity. But how about the pay scale? Is this a time when we can address the pay scale so that we're attracting the best possible caregivers, either in homes or in facilities? So any thoughts about, Rahm Emanuel says, never let a crisis go to waste. And is this an opportunity to do something with wages?
Jump in there. So absolutely is the short answer. The current crisis that we're in highlights that on the one hand, we are taking care and providing quality care, both post-acute, where people get stronger and then go home, and long-term care for folks who would otherwise not be at home, but likely be in hospitals. We've been providing that care against chronic, across the country and in Maryland, chronic Medicaid underfunding.
Yeah.
And so we're going to need to work together and remedy that chronic underfunding in Maryland and across the country. That's going to be incredibly challenging given the economic crisis that we faced in our country. The federal government has been the saving grace financially for the healthcare sector during this crisis. I think they've spent almost $4 trillion on the pandemic, equal to roughly 1 year's annual federal U.S. spending. State budgets cannot print money that way, and we obviously have a tax collection and revenue crisis across all of the states. But we're going to have to band together and make sure that we adequately fund Medicaid so that we can afford a workforce. And as Kevin brought up, not just about retooling and retraining folks, but I don't want to have a point that he made be missed, because we all agree on that point. It's about career ladders, and it's about professional development, and it's about the fact that this is a noble, valuable, caring profession, from senior housing all the way down to adult day. And we need to be uplifting our healthcare heroes, and we need to be paying them more. But in a world where 80% of the rates are covered by either Medicare or Medicaid, and where there is basically right now zero Medicare care being provided in Maryland in our sector, with Medicaid being underfunded, we're going to have to make sure in a sector that's 80% funded by the federal and the state government, that funding will support those developments.
Great points. Anyone else? Alison.
I'll just jump in on and just echo, everything Joe said. I think our field is receiving more attention today than maybe it has ever in recent times, and it's not all good. We've all seen the slew of negative news stories, and but it is attention, and it does give us a platform, and it gives us the opportunity to have conversations, to change the narrative, and not just in a professional setting, but even in our personal lives. I feel like I've had more opportunity to have conversations about ageism and all of that, and even my personal life over the last 4 months. So I think until our society truly values elders, we won't value the people who work in the field. And so it just, it kind of gives us the platform to really have these tough conversations and to ask the hard questions. I don't think there's any easy answer, but you're right. We shouldn't waste a good crisis. So,
Kevin, do you want to jump in, or?
Sure. I think Alison and Joe are right on target. When I think about the platform, the past several months, in some ways have gone by very quickly, in other ways they've gone by very slowly. But one of my friends said to me, to Alison's point, a couple of weeks ago, I don't have to ask what your opinion is on this. All I have to do is open up the Baltimore Sun every day. I think Alison and Joe have been kind of in that same boat where, you know, we have been thrust into the spotlight, and we've done our best to direct the attention to the important issues. But something that you know, that Joe said earlier, you know, just really resonates as it relates to this profession. You know, one of our provider members said to me the week before last, our payroll during the month of April was $300,000 higher than it was during the month of March. That's just not sustainable, you know, using any set of metrics. That doesn't even take into account the additional PPE. And I did math. I'm not very good at math, but I crunched some numbers a couple of weeks ago as it relates to stimulus funds. And at least as I calculated a couple of weeks ago, if you average out the acute care, and you know, we all agree, we want the rising tide lifts all ships. We want hospitals to be made whole. We want hospitals to get the funding that they so desperately need. But if you average out in the stimulus package what each hospital would be getting across the country, it was something like around $24 million. Now we know that that's going to be parsed and changed, and you know, over time. But as it relates, it was about $340,000. That's a big delta. And so I think it speaks to the fact that we need to continue messaging as often and as loudly as we can about the needs financially that providers have to be able to pay staff a living wage to care for our most vulnerable. And again, it goes back to how we value older adults in this country. And those who care for them, those are the heroes. They're doing things with very little to no fanfare. They do it because they care about other people, and we're going to honor that. I know that Joe and Alison are going to honor that. We're going to recognize heroes. We're going to continue to do that, but we really need to stick to doing that over the long term, telling those stories so that people hear more than just the stories in the newspapers about you know, terrible things that have happened since the advent of COVID, and we need to continue that messaging.
Great point. Hey, to everyone in the audience, there's some questions that are being asked that we won't have time to address here, but I would encourage you, because they've been shared with everyone. I would encourage you, if you've got an answer, hit the chat function and give that answer. Eric, Kristen, my hope is that maybe we can leave the session running a little bit even after we end it in just a couple of minutes, so folks can get a chance to see if there's an answer to the question that they posed. The last question I'll ask, and I'm going to turn it back to Cass, is, I think it's only fair because it was the first question that was asked, and so it's for Joe and Alison and Kevin. Question was, long-term care medical records, are there long-term care medical records vendors engaged in discussions of how to use data to improve surveillance capacities? Are you aware of any of that happening? Okay.
Is that for us?
Yeah.
Scott?
Yes, thanks.
Yeah, I think we're all aware of several organizations that are working with data and EMRs from a surveillance standpoint and also from a knowledge management standpoint. I think all three of us have been on a number of calls with, you know, one or two key leaders in that area. Kevin?
Yeah, Joe's 100% right. We've all been involved in conversations around how to sort of fast track getting surveillance data where it needs to go. Some really innovative platforms that exist that you know, we're in contact with the Department of Health on a regular basis, talking through what those scenarios could look like. But you know, it will be very helpful if we are able to use that surveillance technology to push aggregated data to the health department proactively so that they can deploy resources as needed early on in the process.
Good. 30 seconds for Alison first, then Kevin and Joe in terms of closing comments, and I'll hand it back to Cass. And I've got a timer going. No, I don't.
So we'll keep it short. I guess I would just say thank you. I think this pandemic has shown a light on our field, and in some ways it's helped us achieve things quickly because we've had to. We've seen great change in advancements in some ways, and I think we just need to continue to work together on many of the advocacy asks, and really just continue the work of combating ageism and helping to change the narrative and lifting up the work of those who are caring for those who are most vulnerable. And just thank you again to Cass and the Alzheimer's Association for organizing this.
Kevin.
I don't have much to add, just to say thank you again to Cass. Cass, thank you for your leadership, Eileen as well, and Eric and the whole team. And thanks to you, Scott, for guiding this conversation. I think it's an important one to continue to have. And as we all become more accustomed to communicating using Zoom and other platforms like this, you know, it's going to be easier to have these conversations on a more frequent basis. And so I wholeheartedly hope that we continue to do that.
Joe.
Add my thanks to Cass and the entire team at the Alzheimer's Association, you know, Eric and Eileen and Christine, everybody. And just, I just think this was a very powerful conversation. Scott, you teed it up well. I guess most of the people know that on the call that I'm a lifelong marathoner, and I'll take two lessons from that. And that is, one is you can't complete a marathon without actually putting in the training. You have to train. And in the end, you never complete a marathon without support. It's a long run, and it turns out to be a community endeavor. And I think what's been a silver lining in all of this is that I've never felt that I've been training alone on this run. I've had Kevin and Alison and a bunch of the other people on this line running alongside me, albeit virtually. But I think it's important to acknowledge that until there's a vaccine, we're all going to be running this marathon together, and it's going to be every bit of 26.2 miles. And there are going to be ups and downs, and the only way we're going to get through it successfully is running it together. So I thank you all very much.
Perfect way to close. And as a runner, your analogy is right on target. Thanks to everyone for participating. My hope is that this is the beginning of a conversation with more to come. Cass.
Yes, well, Joe and Alison and Kevin, you are truly leaders for this time. And I have been so impressed with your comments, and I've learned so much from you, and really appreciate you taking the time to share your insights with our greater community. Scott, you did a wonderful job of facilitating the discussion. Thank you so very much.
Thanks, everyone. We'll hopefully keep this going so that I see there's been some answers to the questions. So if you asked a question and I didn't cover it, look at the chat, and my hope is you'll get the answers. Thanks, everyone.
Thank you.